you got CAT scan vision? Like, how do you know this? Patient from 6 feet away, how did you know this? What are some of the primary LVO red flags that you look for as a neurologist so that we can be looking for them too to let you know when we see them? Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the podcast. Today, I am so excited about my guest. With me today, I have Dr. Shyam Prabhakaran. He is a neurologist and one of the chief writers for the new 2026 AHA stroke guidelines. What a privilege to have in the podcast. Welcome, Shyam.
Thank you. It's my pleasure.
Awesome. So before we dive into this case that I have to go through, can you just tell us, how did you end up a part of the AHA writing these guidelines? What led to this place?
Well, we are all volunteers in our professional societies. AHA is our biggest one for stroke. And as volunteers, we get nominated, we get requested to join various activities, various commissioned initiatives. And this one was one that landed on my lap. Obviously, I was honored and thrilled to serve in this really prestigious and important role. And I got to work with, not only amazing American Heart Association team members who shepherded this from beginning to end, but also just experts from every aspect of stroke care, including nurses, including patient representatives that helped shape this into the final product. So definitely can't take all the credit and certainly not even most of the credit.
Awesome. Well, glad to have you. I've been a nurse for almost 22 years, and it's been cool to see the evolution of recommendations. I remember when Out to Place was the new cool thing, 3-hour time window, and just watching how things have evolved as the research emerges. So I'm excited about what's new today.
Yes.
So in order to highlight all these new changes with the guidelines, I wanted to base it all on a case. So if you're okay with it, I'd like to share a case with you. And then I just have some questions about the case, and you tell me how we would respond to this based on the new guidelines.
Yep.
Okay, pretty classic. A 67-year-old woman with a history of hypertension, type 2 diabetes, and of course, atrial fibrillation is at home when she develops sudden right arm weakness, slurred speech, and facial drooping while she's making dinner. She assumes, I'm just tired. She lays down to rest, hoping symptoms go away, but they don't. 4 hours later, her symptoms persist, and her daughter convinces her to call 911. EMS arrives to find her with persistent expressive aphasia, right-sided weakness. Last known well was estimated about 5 hours prior to her arrival in the ED. The pre-hospital stroke screen is positive, so EMS has to decide between transport to a primary stroke center, which is 12 minutes away, versus the comprehensive stroke center, which is 28 minutes away. Upon arrival to the ER, her blood pressure is 186/98, glucose 142, NIHSS is 9, her non-contrast CT shows no hemorrhage, and her CT angio reveals left M1 occlusion. Okay, sounds like a classic case, right? So first question, we'll start with pre-hospital.
Yes.
From a systems and guideline standpoint, how should EMS think about destination choice regarding primary versus comprehensive stroke center, especially when they're suspecting a large vessel occlusion? Hey guys, so before we go any further, as I'm editing, I'm realizing that we don't actually explain what we're talking about here. We just dive right into it. So just to back up a bit, when it comes to ischemic stroke, there's a clot somewhere in the brain vasculature. Your options for treatment are a thrombolytic, so a medication that just breaks up the clot, basically, and or thrombectomy, which is where you go in through the groin, up into the brain, shoot some dye, find the occlusion, and actually pull the thing out. So typically, every primary stroke center has access to thrombolytics, but only comprehensive stroke centers can do a thrombectomy. And so therein lies the challenge if you are pre-hospital deciding, do I go the extra miles to get the patient to a comprehensive center where they can do this thrombectomy? Or do we just go to the closest one, knowing that time is brain and we need to get this medication in quicker? So that is a challenge. What we're talking about as far as large vessel occlusion. So there's like the main vessels, like the superhighways of the brain, and then there's a bunch of little side roads off those main vessels. And the large vessels or large vessel occlusions, typically those are the ones that you can actually go in, grab a hold of and pull out. But the smaller vessels, you really can't get to them very well. So for the small vessel occlusions, TNK or TPA, a thrombolytic alone often will make the symptoms remarkably decrease or go away altogether. But if it's a large vessel occlusion, the TNK will definitely help, but thrombectomy is the patient's best bet at a full recovery, with best bet of a good prognosis with regards to deficits in the future. So therein lies the challenge. Do we go to a primary stroke center and get the treatment, the medication in faster, or do we drive a little further and go to a comprehensive stroke center where they can do thrombectomy? And what's new in these guidelines we're about to talk about is the windows with which we can do the thrombolytic versus the thrombectomy. Okay, now back to Dr. Prabhakaran.
So in a system of care where there are more than one level of stroke center, which in this case, it sounds like there is because there's a comprehensive that's 28 minutes, I think you said, that makes at least the decision more complicated as opposed to being in a region, a rural region where there's no comprehensives or thrombectomy centers where you don't have that option even at your disposal. So the recommendations that have been distilled in the guideline is that in a region where there is this opportunity for choice between a primary stroke center and a comprehensive, if it's reasonably close and you're suspecting a large vessel occlusion, I think the prevailing, certainly non-randomized evidence is that going to that comprehensive should increase the chances of getting sooner to a endovascular therapy, which in this case, it looks like the patient is going to be eligible for. So I think that's the first recommendation, which is in the field, if you suspect LVO and you have that option of choices and it's reasonably transport-wise similar in time, better to go to that thrombectomy capable center. And in this case, because of the time window had elapsed already beyond the chronologic thrombolytic window, going to a primary would not necessarily result in thrombolysis. And so they'd be shipping them to the comprehensive almost certainly. And so I think the choice there was to get to the thrombectomy capable.
Okay. And then speaking of the time window, so this patient arrived to the ER at 5 hours since last known well. Historically that would have excluded her from thrombolytic, but how have time-based windows for reperfusion therapies evolved?
Yes.
And how should bedside clinicians be thinking about time in stroke care today?
So this is a complicated question. The guidelines and the writing group reflected on this. It is evolving, but largely still is based on how quickly you're likely to get thrombectomy, or even if you're eligible for thrombectomy. So in the presence of an LVO outside of 4.5 hours, up to 24, other than in the scenario where you are unlikely to reach a thrombectomy center, and those studies were done in China, where there were patients who were LVO present but unlikely to go for a thrombectomy, thrombolysis is an option. But it's not actually proven to be an option if you're likely to get to a thrombectomy center. And in the US and in many parts of the world where there's a lot of thrombectomy centers within reasonable distance, the studies that have been done that looked at quickly getting to a thrombectomy center and doing an endovascular thrombectomy with or without tenecteplase, there was no benefit of that additional tenecteplase in that window if you have an LVO and you're going to get to a thrombectomy center and go for EVT. So in this case, because they're going to be at a thrombectomy center, the thrombolysis is not necessarily going to be required and is not recommended.
Okay, so a very nuanced answer
very
to my complicated question.
Because you're going to ask me later, what if you don't have an LVO? What do you do there?
How did you know?
Yeah.
How did you know? Okay.
That's the nuance.
Yeah. Okay, so let's talk about that. So once we've ruled out hemorrhage from a non-contrast CT, what does the new guidelines say about advanced imaging, CT angio, perfusion imaging? How does that guide our steps with regards to this window for thrombolytics?
So we are saying in these guidelines that those advanced techniques, CT angiogram, of course, is necessary to diagnose the LVO to begin with. So you do need vascular imaging. That's the angiogram to look at the blood flow blockage at the MCA, the M1. However, the additional imaging that might be performed using perfusion, which is a tissue assessment of blood flow and what's salvageable, what's already predicted to be core infarction, is not absolutely necessary to make a decision around thrombectomy. That you can do it based on the aspect score. The aspect score is a plain CT rating of how much tissue looks like it's already established injured. And the guidelines are a departure from previous iterations where it was based on perfusion selection or advanced imaging selection. And now we've simplified it to just based on, or could be just based on aspects alone. So if the aspect score in this patient under 6 hours is between 3 and 10, this person is eligible for thrombectomy even without any other advanced imaging. Now, a lot of places will still do the advanced imaging because the contrast is already being given as part of the CT angiogram, and they can largely go ahead with minimal delay and get a CT perfusion. So we're not absolutely saying don't ever do it. We're actually making a recommendation that you don't need it for decision making, but you can use it if it's helpful for prognostication and risk-benefit balance.
Okay, let's back up again and talk about the imaging options here. So we have a non-contrast CT, which is all that's required to rule out bleeding or a giant tumor as the source of symptoms. So you can give a thrombolytic after only a non-contrast CT if the patient doesn't have any exclusion criteria like risk of or current bleeding, and if they're within the window. Okay, so we need to know first and foremost, is there bleeding in the brain? If a hemorrhage is present, treatments like thrombolytics would be very dangerous. In addition to ruling out bleeding, clinicians also look for early signs of ischemia using a scoring system called the ASPECTS score. ASPECTS is an acronym for the Alberta Stroke Program Early CT Score. The ASPECTS score estimates how much of the middle cerebral artery territory has already been affected by infarction. And the scale starts at 10, meaning the brain appears normal, and 1 point is subtracted for each region that shows early ischemic changes. So a higher score indicates less established infarction and more potentially salvageable brain tissue, while a lower score suggests that a larger portion of the brain has already been irreversibly injured. So low scores are worse or more evolved strokes, carrying with them worsened long-term deficits and increased risk of complications from either intervention. So, after the initial CT non-con and hemorrhage has been ruled out, the next question is whether a major artery is blocked, which is where the CT angiogram or CTA becomes important. So CTA involves injecting contrast dye and imaging the cerebral blood vessels to directly visualize blood flow through the arteries. That's how we determine if we're dealing with a large vessel occlusion, such as a clot in the internal carotid artery or the M1 segment of the middle cerebral artery, or if the clot is in a tiny offshoot of one of the main vessels, which means it would be a smaller vessel, a smaller clot, and therefore harder to get to. So identifying a large vessel occlusion is critical because these are the clots that can potentially be removed with mechanical thrombectomy, the procedure in which a neurointerventionalist, a physician who was in school forever to cross-train as a neurologist and an interventional radiologist. So they go under fluoroscopy, they find the clot and physically remove it. But again, not every patient having stroke-like symptoms is a candidate for a thrombectomy. Some of those clots, even though they're causing major symptoms, they might not be large enough to even retrieve. So in some patients, particularly those who arrive after symptom onset, like later after symptom onset, or they wake up with stroke-like symptoms, clinicians really need more information about how much brain is already infarcted or dead and not salvageable versus how much is still salvageable. The salvageable part we call the penumbra. This is where CT perfusion imaging comes in. So the CT perfusion measures how much blood is flowing through different regions of the brain and helps us distinguish between infarct or dead core and ischemic or dying penumbra. So there's infarct core, ischemic penumbra. The infarct core represents tissue that's already experienced such severe and prolonged lack of blood flow that it is unlikely to recover. And then surrounding that core is the penumbra, which is the zone of the brain that is underperfused and maybe dysfunctional, but not yet permanently damaged. And this tissue is essentially at risk, and if blood flow can be restored quickly enough, it may recover. So clinicians look at the relationship between these two areas, and we call this the core to penumbra mismatch. And when the infarct core is relatively small, but the penumbra is large, well, that suggests there's a significant amount of brain tissue that could still be saved with reperfusion therapies like thrombolytics or thrombectomy. And this is huge. This is the shift that I've seen in my career. It's using imaging to guide therapy. It allows us to intelligently weigh out risk versus benefits. Like, both thrombolytics and thrombectomy have risk. So knowing the size of the clot and how much damage has already been done allows us to decide if the risk of intervention is even worth the risk. Historically, treatments were strictly limited to narrow time windows after stroke onset. However, perfusion imaging now allows clinicians to identify patients who still have a substantial salvageable brain, even many hours after symptoms began. So in these cases, the presence of a large penumbra compared to the infarct core supports aggressive reperfusion strategies because restoring blood flow may prevent the penumbra from progressing into permanent infarction. So together, non-contrast CT, CT angiography, and CT perfusion provide like a layered understanding of the stroke. First, confirming that the event is ischemic rather than hemorrhagic. Then, identifying whether a major vessel is blocked, a large vessel occlusion, and finally determining how much brain tissue may still be saved. So I know that's a lot, but even though we don't order or interpret these images as nurses, I think it's important to know what we're looking for as a team so that I can anticipate a patient's course of care and help expedite all the pieces that are within my control. Okay, let's get back to how we apply all of this with our current guidelines.
Let's break it into two pathways. For thrombolysis, right?
Mm-hmm.
That's the blood thinners intravenously. We still have your standard 4.5-hour treatment. Yes, that's based on lots of trials that using a time window-based approach, you can treat up to 4.5 hours from last known well, and there's benefit in doing that. Outside of 4.5 hours, what we're saying in these guidelines is there is a select group of people who probably don't have an LVO, right? Don't have a large vessel occlusion, but they have a mismatch between tissue that's already injured and core infarction and tissue that's salvageable. And that could be based on MRI-based approach, like diffusion-weighted imaging and FLAIR imaging, and perfusion-based approaches, CT perfusion, looking at the penumbra versus the core. But if you have an LVO, that's the but.
Mm-hmm.
If you have an LVO, and that's what you find outside of 4.5 hours, thrombolysis doesn't seem to be additive if you're going to a thrombectomy. It's only possibly beneficial if you're in a region of the country or the world where you're just not going to get to a thrombectomy center. There is some potential that thrombolysis in that population could be useful, but we largely say in these guidelines that if you're in a place where you're likely to go for a thrombectomy, the next step is thrombectomy.
Okay.
That 4.5 to 24-hour window with an LVO.
Gotcha. So a thrombectomy is just around the corner from CT. skip the thrombolysis if you're at 5 hours and go to thrombectomy.
That's right.
But if you're in the middle of nowhere and your patient's best option for reperfusion is going to be giving thrombolytic, even at the 5-hour mark, that would still be recommended because there's no option for thrombectomy.
Then you would need that selection to be based on the perfusion or the...
Okay.
Yes, exactly.
Got you. Thanks for clarifying that. And I think that's good for nurses to know what kind of facility do you work at so you can know what you're advocating for, what you're rushing to make happen. Do we need to rush this patient off to thrombectomy or do we need to rush to get that T and K drawn up and ready to administer to the patient?
That's right.
Thank you. Okay, let's talk about blood pressure. So this patient's blood pressure was a little high upon arrival, which that's what our body does to compensate and to try to get perfusion around the circle of Willis. But how do we manage this patient's blood pressure? What are the recommendations from these guidelines for this one? Hey guys, I want to take a break to tell you about another great podcast I think you're really going to love. In the Heart of Care, it's hosted by Dr. Ash Panchal, who you may remember from episode 140. He's an emergency physician and resuscitation expert, and it's all about what it really takes to build high-performing clinical teams. I get asked all the time, how do you stay ready for emergencies? And the truth is, it's not just about knowing ACLS. Readiness goes beyond clinical head knowledge. It's about mindset, communication, systems that actually work, and practicing like it's real. Each episode dives into real stories from the front lines, code events, simulation wins, training pitfalls, and breaks down what it actually takes to build team confidence and improve patient outcomes. So, if you're a nurse, educator, or clinical leader who cares about improving outcomes, go check it out. It's In the Heart of Care, wherever you get your podcast. Okay, now back to the episode.
So because they're not going for thrombolysis, because they're not eligible, there's no immediate need to lower. What was the blood pressure? Remind me again.
186/92, I think is what I selected.
So there's no need to jump on that to lower it immediately because there's this blocked vessel, right? There's an LVO. And in that setting, lowering that before you've done any type of thrombectomy or reperfusion could actually extend the damage. So we would not do anything about that blood pressure. It's not super high or dangerous. And you would try to get that person to thrombectomy quickly. And post-thrombectomy, you'd want to lower that to under 180/105, but not necessarily drop them to excessively low numbers like less than 140 systolic, because there actually is still some harm associated with aggressive blood pressure lowering, even after you've done the job of opening the artery.
Gotcha. Okay, so for bedside teams, nurses, physicians in the ER specifically, what do you feel like are the highest impact actions in the first 15 to 30 minutes upon arrival that's going to greatly influence the patient's outcome based on these current guidelines?
Yeah. So rapid imaging, which you mentioned, you got to get them to a CTA at a minimum. If you did CT perfusion as additional imaging, as long as it wouldn't have delayed the rest of the care, totally acceptable. It's a 2A recommendation to do advanced imaging. But CT and CTA are a class 1 recommendation. You need to do that as quickly as possible. That's point 1. Activating your team is, of course, point 2. And if you could have pre-activated them because your ambulance called you and said, we have a suspected LVO, even better. So the team is ready. And then, of course, having those assessments medically to make sure that they're stable and then quickly taken to a thrombectomy suite, a cath lab, when the team is assembled and they're ready to go. And I think that's that time to groin puncture, time to reperfusion, which is one of also the class 1 recommendations, is that as soon as you can do it, still the better.
Okay, awesome. Just a side tangent here. Our neurologists are so awesome at my hospital. I have responded to so many stroke alerts, and they're just approaching the patient. They look at him on the stretcher.
Yeah.
And just from quick eyeball assessment, they say, activate the team for thrombectomy.
Yes.
I'm like, what, you got CAT scan vision? Like, how do you know this? Patient from 6 feet away, how did you know this? What are some of the primary LVO red flags that you look for as a neurologist so that we can be looking for them too, to let you know when we see them?
So I think one of the cardinal ones, of course, is hemiparesis. So one side is not moving. And accompanying that, sometimes there's gaze away from the side that's weak, and also head turn and eyes that are going the opposite way. So when you see, that's why sometimes you can see it from across the room. Their heads turn one way, their eyes are turned one way, and their opposite side is weak. that is hard to be anything but an MCA stroke. And so your radar, even from across the room, is like, okay, this looks real. So those are cardinal cortical and motor signs of a large vessel occlusion. Somebody who's aphasic in a left hemisphere, right, pattern, in most people, the left hemisphere is language dominant. If they're aphasic or mute, unable to produce speech and has weakness on the right side, that's hard to be anything but, again, a left MCA syndrome. Likewise, for the right side, it would be left-sided weakness and looking away to the right and not paying attention to the left and having neglect. So these are like some of the common signs. So motor, language, gaze, and head deviation. And then more subtle things that are not maybe as so simple as across the room, but if you were happening to do a full assessment and you did visual testing and you saw there's a field cut one side, they can't even see or blink to threat on that side if you're testing their vision and seeing if they blink. Having a field cut is a cortical sign, a sign that suggests a large vessel occlusion. So those are kind of some of the cardinal anterior circulation signs of a large vessel occlusion. Posterior circulation is more challenging. Someone might be comatose and you could be thinking anything. You could be thinking drugs.
Is it a bleed or yeah?
Yeah, you could be thinking anything. Seizure, you could be thinking drugs, you could be thinking kidney failure, liver failure. And so there you do need a little bit more of a detailed examination to look for sometimes what we call long track signs, posturing with pinching, pupillary changes, eye movement abnormalities that are elicited at the bedside to raise the level of suspicion that this is a basilar artery occlusion, which is a posterior circulation large vessel occlusion. And so those things, I think are really important. That clinical intuition is still key, because if you don't identify it or suspect it, you're not going to do the imaging or the activation of the teams. So it's still so critical that your nurses and your docs are tuned in to the cardinal signs of a stroke and then what is a large vessel stroke.
Thank you so much for that. Okay. So in closing, when you reflect on your practice and all the literature that informed these new guidelines, what would you say are the primary pearls you want my listeners to walk away with today? What are some common pitfalls that they should be avoiding?
Yeah. So pearls are, there's now a larger toolkit of options, and we should be all aware of them because patients benefit from access to these therapies. And that includes thrombolysis, of course, in 4.5 hours, and in select patients after 4.5 hours without large vessel occlusion for the most part, because if you can get to a thrombectomy center, that's even better for them, and the thrombolysis doesn't really help. And then on the thrombectomy side, there is an expanded window of eligibility, including those with larger cores. That means that more tissue is injured and still they benefit from thrombectomy. So don't count them out. Don't be nihilistic. Actually do something for them, because they still are going to be better if you get them to thrombectomy than if you think, oh, there's nothing more to do here. Actually, they'll do better. And basilar occlusions, as I mentioned, remember to have that radar up if somebody's comatose to look for a basilar occlusion with CT angiogram early. And then what are the things to avoid? Well, I mentioned a blood pressure lowering briefly, but we now know that aggressive blood pressure lowering to under 140 systolic after intravenous or thrombectomy, and blood glucose lowering to under 130 milligrams per deciliter, neither of them help outcomes in patients with acute ischemic stroke. So maybe the knee-jerk wanting to control things that look abnormal on numbers, we don't have to be so aggressive. We can let certain things be a little bit abnormal and then manage them more subacutely and chronically. Those are some of the things that I would say are takeaways. I think the primacy of getting people access to these treatments is still so critical that we have our systems to really, really work on that, emphasizing if a person's going to one hospital, then you have to really be quick about getting them to the second hospital. That's door in, door out, such a critical quality improvement area. And then our EMS colleagues being able to make some choices in the field based on their assessment, hopefully using a scale, like an LVO scale, and saying, okay, I got somebody I'm suspicious of an LVO. I have a choice. And which one would I go to based on the clinical situation? And then finally, we do enter into pediatrics here for the first time. And that is, not the case you presented, but we're trying to open the door to our youngest patient population where we need more evidence, no question. There's not as many data and trials, but we also need to be primed for that. That means we have to have systems in place. We have to have screening in place. We have to have capabilities and testing. Those things will enable more research and they'll enable more evidence that will help raise the guidelines for them.
Right. And if we're not looking for stroke in them, we're not going to find it. So definitely the awareness that it exists and then what to look for, I think is so valuable in improving outcomes for that patient population as well. Shyam, this was so great. Thank you so much for your time today. I will put a link in the show notes to the new guidelines. You can read all 100 pages for yourself. It really was great. I'm excited to get this podcast out to my listeners. So thank you again for your time. Thanks for your expertise. Have a great rest of your day.
Thank you, Sarah. It was really a pleasure. And thanks for taking the time to read it and also interviewing me as a conduit of learning.
Yes, such a pleasure. Thank you so much.
Bye-bye.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.